Good morning, and I would like to welcome everyone who is present in the chamber and all those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would like to add that for those of us in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception and assemble in the car park at the front of the building and await further instructions. I would also request all members to place their phones on silent and to try and ensure everyone has the opportunity to ask a question, to ask a maximum of 2 questions per item, and to keep these succinct and concise. However, I will close down the debate to ensure we keep to time if needed, and would ask you indicate early to guarantee your question. As the meeting is being streamed in the usual way, I would like to remind you that all your comments will remain accessible online, as the meeting recording remains on the council's website. I would like to welcome Derek Ward, the County Council's Director of Public Health, who is present in the Council chamber today, and I will introduce other presenters as we reach their item. I'll now move into the agenda. Agenda item 1, please. Apologies for absence.
Thank you, Chairman. We've received apologies for absence from Councillor Kendrick, Councillor Susanna Welbury and Liz Ball, but we do have Colin Warren here today as Liz's replacement, and we've been advised that Councillor Morgan is running late. And also, Chairman, we've had an apology for absence from Councillor Sue Woolley, Executive Councillor for NHS Liaison, Integrated Care Systems, Registration and Coroners. Thank you, Chairman.
Thank you, Trina. We'll now move on to agenda item 2, declarations of members' interest. This is an opportunity for members of the committee to declare any pecuniary or other interest. Do members have any interest to declare at this point? No? Okay, thank you. In which case we'll move on to agenda item 3, the minutes from the 13th of September. This is to confirm those minutes as a correct record, and as the committee has had the opportunity to read these in advance, I plan on taking these en bloc. Is there a proposer? Thank you, Councillor Mackinson-Sanders. Seconded, Councillor Cleaver. All those in favour, please show. Okay. Have you got all those, Trina? Yeah. Okay. Abstentions? Thank you. And any against? Thank you. In which case they're carried. I'll now move on to agenda item 4, the Chairman's announcements. My announcements were circulated as part of the agenda, and supplementary announcements were circulated on the 3rd of October. Does anyone have any questions on the announcements? Councillor Smith, please.
Thank you, Chairman. With regards to item 6 in your first announcements, it's deeply concerning that yet another NHS dentistry service is no longer in existence. This to me, Chairman, seems to be an issue of epidemic proportions and needs urgent action by central government. There needs to be a frank and honest conversation that the current contract is totally not fit for purpose, and the false premise of only 50% of the population wanting or needing NHS dentistry is nonsense. Dentistry isn't cheap, even with an NHS dentist, Chairman. And Her Majesty's government must ensure that our constituents receive value for money for their national insurance, which they pay through taxation for, and pay obviously for the NHS, but dentistry isn't even covered by that, Chairman. You pay on top of that, as I'm sure we all know. And quite frankly, Chairman, for those people who've lost their NHS dentists, and it seems to be an ever-increasing number, their national insurance obviously isn't being used for value for money because they're now being forced to either travel further distance at greater cost themselves, and some won't have that option, Chairman, or it's a case of go private or don't have anything. So if we can write to the relevant ministers, Chairman, I think we would be doing at least something, even if we can't change the situation ourselves.
Thank you, Councillor Smith. I think it's something that we've picked up upon previously when we've had the items in front of us, and we have written to our MPs asking them to support having something similar to a dental college or some form of courses to encourage those, because we've seen with the university having medical degrees and courses there that, of course, you grow your own, you keep your own, and it's a similar approach. But overhaul of the contract is something that's clearly needed. And I know people like Ken Hume have been very vocal in trying to ensure that that happens, as well as Health Watch, who, of course, have been to Parliament and in front of committees to try and get these points across. So it's something I think we all can well and truly agree on. Councillor Mackinson-Saunders.
Thank you, Mr. Chairman. I ought to declare an interest because I was a patient at this surgery, and it was nothing to do with the contract, the reason it closed down. So whilst I appreciate the comments that have been made, I don't think they're apt in this case. Thank you.
No, thank you for that, Councillor Mackinson-Saunders. I think there's much more involved, certainly, but yeah, I take that on board. Any other comments or questions on the announcement? No, in which case do I have a proposer that we note these, please? Thank you, Councillor Smith, and seconded Councillor Hayes. All those in favour, please show. Thank you, that's supported. In which case, we'll now move on to agenda item 5, urgent and emergency care update. This item was circulated as part of the agenda pack on pages 19 to 87, including the NHS England's delivery plan for recovering urgent and emergency care services. This item focuses on current services and future plans. I do not plan to allow questions or discussions on decisions taken last year as part of the acute services review, as we need to focus our time on the present range of services. I'd now like to welcome our presenters, Claire Raybould, Director for System Delivery, NHS Lincolnshire Integrated Board, Julie Frake-Harris, Chief Operating Officer for the Lincolnshire Community Health Services NHS Trust. As this is an extensive item, could I ask you to present the report in 2 parts? I suggest firstly you present the first part of the report up to including section 5, and we will then have questions on that part. Then the second part of the report from section 6 onwards, followed by questions on that section, plus strategic questions. We also have the item on winter planning as a separate item after this one, and I'll hand over to you for the presentation and questions after. Thank you, Claire.
Thank you, Councillor Mosey. Morning, everyone. Hope you're well. So I'm Claire, and this is Julie, just so you know which one's which as we go through today. So I just want to start by saying, obviously you've got the paper in your pack. Nationally, the NHS and the care sector has experienced sustained pressure over the last few years, really, just before COVID, but particularly during COVID. And we've experienced the busiest summer on record this year for the NHS, both here in Lincolnshire, but also nationally. And that has placed a lot of pressure upon our services, as you'll be aware. Some of this will link to the health of our population post-pandemic and the ongoing recovery that we've got of services, which we've talked previously here at committee. And as we sit here today, we're in the 3rd day of joint action for industrial action of junior doctors and consultants, but also radiographers in many trusts, although that doesn't affect our main acute provider, it does affect our major trauma centres that are around us. So it's really challenging for staff at the moment, and everyone's working really, really hard to do the very best they can. But we do recognise it's not always been possible to deliver the very best and most timely care that we would want to deliver, and that we know patients have at times experienced long waits and poor experience. That's not what any of us come to work to do in the NHS. We are striving daily to improve that. So I just wanted to give that bit of context. So I will take the paper as read, but just to go through some elements with you. I came here in March and talked quite extensively about the recovery plan that had been published, and you've got that in your pack. The 2 main focuses on that, there's a set of pledges in there, as you know, and a set of ambitions, but the 2 main focuses in terms of targets for the NHS are patients being seen quickly and moving back to 76% of patients being admitted, transferred or discharged within 4 hours by March 2024, with further improvement in the year after that, recognising the national standard in the Constitution is still 95%, but the recovery trajectory has been set because it's recognised that we can't meet that at the moment. That target, as you'll see from the pack, so for Lincolnshire, our trajectory was 67.8 in August, and we achieved 67.2, so just short of that. I can confirm that in September we actually are on trajectory, so things are getting better for us. In terms of the second target, it's about ambulances getting to patients quickly. We have rehearsed here many times about the challenges in Lincolnshire, our geography. We don't have any major road networks. It does make it more challenging to achieve that 30-minute target. However, that is what we're trying to do in terms of improving. And we have made quite significant improvements this year from where we started the year, with both the ambulance response times but also the handovers at our emergency departments, both in county and on on our borders, but it does remain challenging and it can be a bit volatile for various different reasons, which I'll come on to that are in the pack. As I mentioned previously, there is a national recovery plan, there is regional work, and all of that is detailed in there in terms of the priorities that have been set out for us nationally, but also what we're trying to do locally here in Lincolnshire. We've got a new governance structure for urgent and emergency care in Lincolnshire, well, a refreshed governance structure, I would call it. So we have an urgent and emergency care partnership board, and that is made up of all health and care commissioners, but also our key providers. It includes North West Anglia Foundation Trust and North Lincolnshire and Goole, so that we're covering our main providers where patients to the north of the county and the south of the county would use as a main provider. And that partnership board really oversees the delivery of the urgent and emergency care programme, which includes the recovery programme, as you can see in the pack. So in terms of what we've set out as priorities, we've just done a refreshed strategy, and our priorities are same as they've been always and same as what's in the national priority list. But in addition, we know that frailty is a big concern for us in Lincolnshire. We know we've got an older demographic, and if we don't do something different, then demand will outstrip capacity. So we've got a whole programme of work on frailty at the moment. There are some very targeted interventions for this year ahead of winter, so around acute respiratory infection. So we don't have hubs for that in Lincolnshire currently, and we're about to implement some of those over the next couple of months in readiness for the peak of respiratory season during winter. We're also trying to do some work around what we call a single point of access for clinicians, because we know we have a multitude of pathways that clinicians can use to support patients either in their own home or if they need emergency treatment quickly. But they're quite difficult if you're sat with a patient and you need to access those quickly. So a single point of access that the clinicians can refer into and will be then supported is one of our ambitions. And we list all of the other local priorities in the pack. In section 4 of the pack, you've got details about our approach to system coordination, and I talked about that again when I came in March. There's now a new specification for system coordination centres, and we already meet that specification in Lincolnshire, but we are making some further enhancements to that. That's a centre that operates 8 till 8, 7 days a week in Lincolnshire, and you can see the makeup of who's involved in that. So that's all our main providers, our adult care colleagues, and obviously all of the services that would impact on urgent and emergency care, but also elective care. So it's not just primarily urgent and emergency care. And there is a new OPAL framework, which is the operating pressure escalation levels framework that's been released, and obviously that will be picked up by that centre as well. And then section 5 in your pack talks about pre-hospital care. So I know that you were keen to hear a bit more about what we're doing around pre-hospital care. We remain really focused on, we know that a lot of people end up in emergency care that actually could be better cared for in a different setting. So we're really keen that we want to maximise the use of people being able to be looked after in their own homes or their place at the home, whether that be a care home or their own home. And make sure that we wrap services around them where that's appropriate to do so. And then therefore that reduces the risk of them going into hospital unnecessarily, but also then becoming deconditioned whilst in hospital and finding it difficult to get back into their normal home environment. So there's a real focus on that across health and working in partnership with adult care to make sure that we maximise all of the pathways that we've got. So we've got virtual wards, which are detailed in your pack, and we've got those for cardiology, frailty, respiratory, complex neurology, acute medicine and hospital at home. We also have urgent care response, which has been in place for a while, and we're still continuing to make sure we make use of that. But as I mentioned earlier, sometimes it's just that, how do clinicians get to all of these pathways when speed is of the essence? And then we also have many other services in the community, so such as falls, etc., which again we talk about in your pack. So what we're trying to do is integrate some of those services so that they're better connected. We know that that's partly one of the issues we have across healthcare is it's not always very integrated and patients have to tell their story multiple times. We're trying to do that work outside of hospital, and Julie's team in the Community Health Trust are obviously leading a lot of that work. So I'll just move on to urgent treatment centres. I think you wanted an update on where we are with those. So you can see in the packet details the urgent treatment centres that we currently have in Lincolnshire, and we also have a GP-led minor injury care service at Sleaford, and we also have a minor injury service provided by NWAFT out of Stamford Hospital, and they obviously all exist. We are doing a commissioning review of those services and our GP out of hours services at the moment, because demand has changed, and it is about time we re-looked at that to see have we got the balance right in terms of where we've got services and the right capacity able to meet the demand in those services. So that's a commissioning review that we're undertaking, we're about to launch imminently. We know that it has been, on occasions, we have had to close a service either for a few hours, or we may have had to close it overnight. And often that does create angst for patients, and we understand that, but the assurance we'll give is when we do that, we have exhausted every other opportunity, and it's usually a result of critical staffing that we just can't maintain safety. So some of the periphery UTCs, for example, that are open overnight, that probably only see 3 or 4 people, there's usually 2 staff, so you'll have an advanced care practitioner and a healthcare support worker. If one of them is not there, it's not always safe then, obviously, to maintain that service in the way that we do. So we're trying to make best use of NHS resources and do it as we can. But that's partly why we're commissioning the review, so that we can have a proper look at what is the capacity and demand and have we got the balance right across our services. And then you also wanted to hear a bit, obviously we mentioned the acute services review earlier, so obviously there will be a change at Grantham, but that's already been consulted on, so I wasn't going to go into that in any detail, but obviously we are still on track in terms of the work that we're doing around there and putting a 24/7 service into Grantham, which would be really great for that population. And then we've also got the 111 service and our clinical assessment service. So 111 is operated by Derbyshire Health United, and the clinical assessment service is operated by Lincoln Community Healthcare Trust. The contract for 111 is actually currently being re-procured. In fact, the procurement has concluded, an award has been made, but we're in a standstill period at the moment, so we're not able to say any more about that. That's a service that will operate across 11 ICBs, so 11 integrated care boards in the East and West Midlands, and quite similar with how they run across the country. So they're usually very big geographies because they have to be able to have interoperability between each other. But what we have in Lincolnshire is an ability that where a clinical assessment is made, that transfers to a local service who understands the local services in Lincolnshire, and that's really important to us, and obviously that's detailed in the pack as well. So I think I'm going to pause there, Chairman, if that's okay, and happy to take any questions on that so far.
Thank you, Claire, that's great. Councillor Smith first, please.
Thank you, Chairman. Could our presenters please explain how virtual wards work in practice? Because I note at 5.1, most of the conditions that are mentioned there, excluding, say, frailty, where it could be appropriate for the use of them, most of those conditions, when I sort of think of them and they come to mind, it comes sort of very left field, that you wouldn't be in a hospital setting for them because of their nature. So I'd be very grateful if our presenters could explain the working of this and how it still delivers the standard of care that obviously you want to see and patients need, and the outcomes for residents, and especially in, say, a rural division like mine, because if you're using, say, digital means to do that, internet is going to be a problem, because some of my parishes are very, very rural and have very poor signal. Phone will be another problem, because equally, again, some have very poor phone signal for mobiles, for example, and most people now, because of cost, don't have landlines. So it's just how that would work in practical terms as well. Thank you.
Are you comfortable, Chair, that I respond? Thank you ever so much. It's a great question. Do you mind if I take it in 2 parts? The first being the concept of virtual wards. I think it's particularly for our long-term conditions. Our patients, our experts by experience, really tell us that to have the choice to be treated and be supported outside of an acute hospital setting is really important to them, and particularly with rurality as well. You can imagine. So this is an important challenge for us to be able to deliver. Actually, you'll see that the list is fundamentally those long-term conditions. So we're talking about individuals, say if you take cardiology, they have been supported by our acute physicians for many years. We know when an individual is starting to need more or less acute support. So in fact, the list is predominantly comes from those LTCs, and therefore we have good rapport with the patients, and the patients have good rapport with both the acute and the community providers. So that's why they're our virtual wards, and they do work really well with great outcomes, particularly for primary care, being able to step up somebody into a virtual ward rather than moving straight into a ED and potentially admission, which is actually never great for our patients or their families. Then I think the connectivity issue is an absolutely real challenge. Our virtual wards are supported by technology. Some of that may be as simple as your watch and other abilities that do work well with reduced Wi-Fi and other provision. It's a choice as to whether it's safe to put somebody on, and obviously that's a large part of the assessment. We also work through whether you are able to take your vital signs, your respiratory levels. It doesn't all necessarily have to be done through technology in order to input the information. Our teams link in with those patients more regularly. I take the landline issue, but we work that through case by case, counsellor. So actually our ability to support nearly 150 patients at the moment through virtual wards is a great success, and it's a really good choice opportunity, and also does take the pressure off our acute providers from a bed position. So we're able to use our virtual wards to step out of acute care as well quicker. It reduces that concern that somebody may need some extra support that we're able to flex in the community. I hope that is helpful in taking those two aspects.
No, thank you for that. It's very helpful because I knew what they were, but not quite how they operate. So it's very helpful, and I'm sure we've said here before, Chairman, that there is a countless pages and pages of research that you only really want to be in an acute setting when you absolutely have to be, and then if you are in there longer than you need to be, you actually deteriorate physically and potentially mentally. And obviously being aware of the, as you say, the bed position in acute wards and accident and emergency. If people, as you say, people want to be understandably treated at home, so if we can do that safely, then no, that's brilliant. And thank you for going into some detail and explaining that. Really appreciated.
Thank you. I've got Councillor Parkin next, please.
Thank you, Chairman. It's good to have Derek here as well, because this probably is more aimed at you, actually. On page 43 of the papers, we talk about meeting the challenge and focusing on those 5 areas, and I don't quibble with any of those 5 areas at all. What I think concerns me is what's missing. And you mentioned falls in your presentation. And we know that there is so much that can be done to prevent falls, whether it's strength training for people, fitness, whether it's yoga, Pilates and all the rest of it, whether it's housing, such a massive issue. All of those things are preventative and then stop you guys getting those people the hard end. So is there something in there about how you are working with local authorities, with health trusts, with the county council, to really ensure that those organisations are aware of what you need from them, not just in falls but in other areas where we are looking at so many people. You will know better than I do how a fall for somebody in their old age just then has that knock-on chain of consequences that can be fatal for them. And yet that's time and time again. I know we're not the Public Health Committee, but time and time again, that is, for me, the synergy that we lack all of the time in these reports.
Thank you, Councillor. So just for the record, I'm Derek Ward. I'm Director of Public Health for the county, but I'm based in the County Council. Really good question. I think just picking up on the falls side of it, as members will know, we have a falls response service that's commissioned via Lives, which is very much an interface between a lot of what Claire and Julie are talking about with urgent and emergency care. It's people who fall, trying to get out to them quickly, which is really important for lots of reasons, but also for individuals who have fallen but maybe non-injurious falls. We are freeing up ambulance capacity. We can get that person back into their own, back up into a seat, make sure that they're fit and well, or safe and well at least, and then provide wraparound support. So we're not using ambulance resources. We're not taking people into hospital and potentially sitting around in ED for hours on end and creating that capacity. So that's one end. You go a little bit further in terms of the preventative area. You talked about balance and stability. That is something that we've just started a pilot on, as you may be aware. It's one of the areas that I've researched academically, and we're using the FAME model, which is a national model around how to help people who are at risk of falling but haven't yet fallen, or maybe have fallen but non-injurious. It's quite an intensive program. It's the best part of a year program to help people build their balance, their stability, to help them understand that if they do end up on the floor, how to get back off the floor in a safe and supported way. And all the evidence base, picking up on Councillor Smith's point about hospitals are dangerous places, is we can train people and support people to be less likely to fall, and if they do fall, to be able to fall correctly, if for want of a better phrase, so that they do reduce their risk of injury. So we are doing all of that. The bottom line is, though, we have a national system, and this is true of most Western countries, that is focused understandably on treatment, and we're talking about urgent and emergency care at the moment, and we all know that an ounce of prevention is worth a pound of cure. What we're talking about is the millions and millions, in fact, getting up towards billions of pounds that we're spending on treatment, and we need to shift some of that spend. That's the national debate, absolutely.
I agree, Derek, that it is a national debate, and I think it's one that we're really poor at nationally, and I think politically, on a small p politically, not party politically, before you tell me off, I don't think it has the platform that it needs and that it deserves. But I still have that challenge back, that to see something in the report that locally, that the NHS are pushing for that and trying to collaborate with local partners on a strategic footing, I think would be really welcome, that we knew there were those local efforts to be made.
Thanks. It is a really great question, as Derek said. I think maybe for a future session, because obviously I have focused on urgent emergency care here, so there is quite a lot of work we're doing around frailty strategy and prevention in the community and primary care. That would pick up more, I think, but this is probably the other end of it, as Derek said. But be rest assured, there's a lot going on in that space. And actually, Julie's just going to touch on something that we're doing. We're piloting just for winter, which is definitely a true collaboration, as you describe.
No, I think absolutely making sure that our linkages and that the whole offer is really well integrated is the absolute key challenge. And as Claire says, for this winter, we're linking the Lives full service with a concept of winter mini joint emergency team with EMAS, with our ambulance provider, which also is moving us into a more sustainable next year, that we're able to support our community teams to understand and be able to support our fallers much more responsively this winter and link through to those services. So I think you're absolutely right, making sure, and I absolutely take potentially your comeback challenge when we come back again. They've fallen by then, Julie. And actually this is about wanting to stop the fall. But actually how quickly we are able to respond to in a joined up fashion to every fall does prevent the amount of harm we're causing and able to support individuals to stay in their own home rather than moving into acute care as an emergency response. So you're absolutely right, and we're completely in that space that prevention would mean we don't need these services, but actually making sure these services are very joined up and get to our fallers the minute they've fallen or as quick as is where we'd like to be in the next best response. Thank you, Chair.
Just two final quick points. I think if there's a huge amount more that we can and we should and we are looking to do. So just picking up the virtual ward idea, absolutely right that we do have digital exclusion. It's not just about broadband connectivity or 3 or 4G, it's about people's ability to use the technology as well. We've done quite a detailed piece of work about digital connectivity and digital exclusion. It's on the council website actually, and that's seen as country leading. It's not just about digital connection. If we want somebody to stay at home and they want to stay at home, if that home is cold, if it's damp, if they have no food, if they have no support, then with the best will in the world, we can provide world-class clinical care, but they're going to end up in hospital again. And so we need to wrap around all of the wider services, and that's where our partnership with our district councils is really important because of the housing aspects that they lead on. Partnership with some of the social care work that obviously the county council leads on and our third sector partners lead on is really important. So we've got to wrap a whole range of support around people to make virtual wards a reality, not just the clinical aspect and the technical digital bit of it, and there's lots more work to do there. But if we get it right, it's not only the right thing for the person, it will save money. And that's one thing that people think about. Prevention is going to cost money. It does cost money, but it saves more. It's the prevention, whether it's stopping people getting sick in the first place or people with existing conditions, making sure we manage them and help them manage themselves in the best way possible, saves the country money. And that's an argument, especially politically at the moment when we've got all of our conferences coming up, is a message that, as the Director of Public Health, I would ask all of our politicians to please raise, because it does save money. It's the right thing for the person, it's the right thing for Lincolnshire, and it's the right thing for the country from a financial perspective.
Okay, thank you. I've got Councillor Wood next, please.
Thank you, Chair, and thank you both for your report. You mentioned about people accessing the wrong services, and I think it opens up wider as to whether there are other services to access. So we have an A&E and an urgent treatment centre in Lincoln, but we don't have anything like a walk-in centre anymore. So people just don't know where to go with GPs at capacity, and sometimes there is just no other option. I'm pleased that we're getting a community diagnostic centre, and I just wondered whether you expect this to relieve any pressure on the current services.
Yeah, thank you. Great question. One of the things we're trying to do locally is encourage talk before you walk. So ring 111 first, because they will direct you to the right services. So they can directly book into general practice. They can directly book into the urgent treatment centre. Both of that's detailed in the report. Because often it is confusing, and I think no matter how we try to articulate that, it's quite difficult. So the simplest message is ring 111 and we will direct you to the right place. Your point about community diagnostic centres, they absolutely will take pressure away from acute and emergency departments, because a lot of diagnostics is all carried out on the hospital sites. Most diagnostics is, and there's very little in the community generally, and therefore the priority is always going to be those urgent cases in the hospitals, and it can often push waiting times out. So having those protected on the community sites is a much better way, but it also is greater access. So we know that some people don't attend for diagnostics, even when they are requested to, whether that's screening or prevention, or whether it's actually because they need to go and have an X-ray. And often that's the challenge because our geography is so big, isn't it? So, but what we're finding with the, I know it's a different item, but with the Community Diagnostic Centre at Grantham, for example, patients are coming from all over the county and they don't mind because actually they can get in, they're seen on time, they don't have to pay to park. So actually having another one in Skegness and another one in Lincoln, and then hopefully the further one in Boston, will make a huge difference. So it absolutely will support. Thank you.
Thank you. I've got Councillor Cleaver next, please.
Thank you, Mr. Chairman. I'm interested in the urgent treatment and out of hours particularly. I notice that you have committed that there will be a full review in this report of the Commissioned Urgent Treatment Centre out of hours provision. First of all, it would be nice to have some timelines around that. I mean, it's now already October, and obviously, presumably nothing will be completed before the end of the winter on that, or is it going to be a very quick one? The other thing that concerns me about it is it appears from the way it's worded that you are going to be reviewing what you already do and not looking at any need for things that you don't already do. You're not actually looking at demand in a more general way, particularly across the areas which don't currently have urgent treatment centres. Obviously, that's a concern. I'd also like to ask you about the Waitless app, which looks lovely, by the way. I know it's been launched. I know it's been recently publicised. I think you've done a consultation on it. It could be very useful. The problem is that unlike 111, it doesn't go across 11 ICPs, so it's not joined up across the border. So those of us that live in border areas of Lincolnshire are unwittingly, can I say that, diverted to places that are much further away than UTCs that are in adjoining ICP areas across the border. And I hope that you can reassure me that's going to be addressed so that the app is much more usable for all of us across the county, not just those who live in the areas served by ULHT. I notice that there is a reference to the minor injuries unit in Stamford. I do recall that in the spring of this year, a reference was made to a review of the provision there because of minor injuries units not being within the NHS framework any longer, and that consideration would be given to it being upgraded to a UTC. Again, there's no mention of that specifically in your report, and I note that nothing is actually happening about that at the moment at all. I've been told that that the ICB is not currently going through any formal consideration about the future of the MIU in Stamford, which again is a concern given that we've not received an update on that for 6 months, having previously been told that it was under review. So I'd love to know what the future of that is. On the question of 111, I do occasionally, and it's not something I get often, but I do occasionally receive concerns from residents that they're not being signposted to the out-of-hours GP service. And I have queried it and not particularly, actually not got anywhere with those queries. Is the advice given by 111 in any way quality audited? How do we know that the right advice is given? How is that quality assurance taking place with 111? I'd be interested to know that, and whether that will again feed into your review. And again, you've said presumably
I think we're on about 5 questions now.
Right, sorry. Okay.
Can we allow them, please, to respond?
Okay.
Councillor Cleaver, thank you.
Thank you, Chairman.
Thank you. Thank you, Councillor, for your questions. So firstly, as I said earlier, so the point of the review of our UTCs and our out of hours is to understand what the demand is, and therefore what we've then got available and where is that. Because we've put them where we've put them, that's history and it is what it is. We need to understand what the demand profile looks like, where are people going, why are they going, and then we can look at what do we need and if we need to be doing anything different. So that is the purpose. So it absolutely will be capturing demand for all of our patients wherever they go. So that's why we're doing that review. So your second point on the waitlist app. So I think I said this back in March. So when we commissioned the waitlist app, the way waitlist works is it'll work with providers that are prepared to share their data platform. So at the moment, we only have data sharing agreement within Lincolnshire, which is why it is just ULHT and LCHS services. So we do recognise that, and we did say that when we launched it. We knew that that meant if you were a border patient, then you're not going to see those services. We do strongly work with those providers and we'd love them to come on board, but that's a kind of phase 2 really in terms of being able to do that. And as we start to see the benefit of waitlist and we do our own evaluation of its impact, then that will aid those conversations with our neighbouring systems and our other providers. On the MIU at Stamford, so you're quite right. I know you've had some correspondence with my chief executive, and so we don't have any current work underway at the moment, other than the review of UTCs and out of hours, which will look at our total demand. So it will pick up where people are going. What I referred to previously is it's a designation issue. So in July next year, you can't technically, you can still have an MIU, but you can't record the activity as an MIU anymore. So it's a technicality in how you record the information. So nothing stop it being there, but technically we should change its name and we should record the type of activity that's there differently. So that's the challenge that we've got. We've been really clear with NWAFT that, you know, we want you to carry on doing what you're doing. I know my chief executive and their chief executive have had lots of conversations about it. So we will pick it up as part of our review, but we haven't at this stage said anything about what the outcome of that would be. We're really committed to the continuing to be the MIU service that there is. What we haven't said is we recognise there's demand for anything different, because we don't know that at this point. So that's why we're saying we're not doing anything specific on it. And on 111, I will let Julie come in, but just to give you assurance, so what 111 does is it uses the directory of services that sits behind it. So if you ring and you live in a geography, it picks up where you're ringing from, and it will direct you to the next available slot from a variety of providers. So it won't always, so if all of the slots are gone, so say you were, I don't know, you're in Louth, and you ring and all of the appointments have gone at Louth, it will direct you to the next nearest appointment. So it isn't always saying that means Louth isn't available, it's just booked. But I'll let Julie come in specifically on that.
Thank you, Claire. So yeah, absolutely. 111 has a bespoke dialogue with you around offering you the quickest appointment closest. Of course, as part of the whole campaign of Talk Before You Walk, if you feel comfortable with that, you can then say, actually, Louth would be better for me. I'll wait and have the next appointment there. But the algorithm supports the idea that you'll be offered the quickest. There is a whole national platform for audit for 111, and that it is really robust and looks through that through the clinical reference group that oversees the ongoing oversight of 111. And I think it's really important that we work with both our professionals and our patients around the best way to get the maximum for each of us out of Talk Before You Walk, because by default that will support everybody being served in the right place at the right time, which ultimately is what we're after. And I suppose, bless you, Derek, he's got a bug, that also to say that as part of supporting our clinicians across the county understanding what's on offer, our winter clinical spa will be supporting that. So we hope our patients, when they're talking to their GP or to the community service that comes into their home, that if they do have curiosities and those clinicians don't know, that they will use the spa, because we want to demystify what we're offering, make sure it is as integrated and as tied up as possible, and it's as easy to access, because ultimately that's the right thing for everybody. And to Derek's point, it's the most sustainable use of any public pound. Thank you.
Thank you. Before I bring in my next speaker, I'd just like to build on something that Councillor Cleaver's raised is, and seeing that you're obviously reviewing the commissioning of the urgent treatment centres, is it likely to result in any proposals to potentially reduce the operating hours of these? And will any significant changes arising from the review be public consultation?
I think the short answer is we don't know until we do the demand and capacity. I think what we do know currently is some of them, their hours are underutilised, but we don't know why that is at the moment. We don't know if it's because people aren't accessing it or people are accessing other places, and that's part of the review, and we need to understand why. So we do lots of listening exercises, and we'll be pulling all of that rich data into what we're doing. But clearly, if we want to change anything, and I don't know if that's where we'll end up, it would require consultation or certainly engagement. It depends on the nature of the change, but it certainly would. You'll be familiar that Newark are doing something at the moment around their UTC, which has been closed overnight since COVID. So absolutely, we would have to do as a minimum engagement, and we'd certainly be coming to this committee. But at the moment, I just don't know what that's going to tell us until we start to look at the demand. And for us, it's about using them effectively. What else could we be using them for?
Okay, thank you. Derek?
Yeah, just 3 quick points in a broader context. I think important to understand demand, but more important to understand need. And that's one of the issues. Demand is the articulation of need, but tends to work where those people who know about services, those people who are more comfortable, they have transport, they have the education and understanding, will demand more, even though they may not need as much as other parts of the community. And it's really important if we want to firstly, make sure that we're helping the wider community, but tackle some of the health inequalities that are inherent in our county as they are across the country. We understand need. The second thing I just wanted to say is that one way that we can do that is we've now got a really complex data set around linking up lots of different data sources in our population health management intelligence system, which is helping us understand how people access services and where they don't access services in a fundamentally different way. And we're using that more and more. We're using it with our primary care networks, but we need to use it to support some of the areas that Claire's talking about, and I'm sure we are, and we'll continue to do that. And the third bit, which is an articulation of that demand question, is if we just meet demand, there's an opportunity cost for that. We are spending money meeting demand in some areas that actually we could get a better outcome if we look at the need elsewhere and provide a different service provision. And I think that's something that Scrutiny needs to bear in mind. Obviously, everybody wants access 24 hours a day to gold class standards, but there's a cost to that, and other people won't have that. So at a Lincolnshire level, we've got to understand that balance and that opportunity cost.
Thank you. And if Councillor Mackinson-Saunders would indulge, allow me to indulge this next question because it follows on directly, and I'll bring you in. On page 26 at section 5.3, the final paragraph, can you please confirm that the Grantham Urgent Treatment Centre will be a 24/7 walk-in service and not 24/7 for bookable appointments, as this is not made clear in the report? And what assurance can you now give the committee that in 12 months' time you won't be back here following the review of the service in Grantham asking to move down to the minimum 12 hours?
So I can confirm it'll be a 24/7 walk-in service. It's not part of the review because it's not a current service, and we've already made the decisions about what we're doing about it. So as much as I can give any guarantee about the health service in 12 months, it's not part of our commissioned review.
Okay, thank you. Councillor Mackinson-Saunders.
Lots of people are stealing my thunder about hours and all the rest of it, but the urgent care place in Louth was closed for 3 nights this week, and the public felt really aggrieved about that because I can tell you, if you did some public consultation in Louth, they'd come out top of anywhere because people so value the service that centre gives, which is excellent. But we were told it was because of the strike. Well, given it's a nurse-led service, we were a bit confused about that. So could you explain that? And how do we ensure that this doesn't happen in the winter? Trying to get to Lincoln, 27 or 28 miles over the wolds in bad weather, down to Boston, hopeless. it's even further. Grimsby, and I'll tell you in a minute about when you go to Grimsby, which follows on from Falls, it is such a valuable service for our rural population, and we have a very large hinterland which serves into it. So I do hope you will listen to the public on that one. Can we look forward to further closures at night in Louth, or is that a feast that you don't know if it's going to happen or not?
Thank you for the question. I'm absolutely happy to unpack where we had to make a strategic decision during industrial action. You're absolutely right, it's nurse-led, but our UTC services are predominantly nurse-led, and in order to support Lincoln and Boston over the industrial action, we needed to move that expert nursing support. So I expect you're aware that the nursing skill mix of our standalone services are our most experienced nurses. They are independent practitioners. We see, treat and discharge as a rule. So therefore we had to make a decision in order to support with the incredible impact of supporting those individuals who have taken their right to strike. In order to support that and make sure we do have sustainable services over these 3 days at our ED departments, we needed to consolidate our most independent practitioners of any multidisciplinary team. I think we've made it for that very clear reason. And I think it's helpful to unpack and understand why a nurse-led service is so incredibly impacted by any member of a multidisciplinary's decision not to be part of the skill mix for a number of hours, let alone days. So absolutely, that's why we had to make a difficult decision. The way forward will come out of the UTC review across the whole, but it was very specific about the industrial action.
So if the industrial action continues, we're likely to have further night-time closures, I guess.
I don't think we can predict it, but clearly, you know, the issue we have is, so if I just take medicine as a division of a hospital, we've had, you know, nearly 80% of consultants and doctors in medicine on strike. So therefore, you then have to bolster that with all of your other skilled workforce across the county. So I don't think we can rule it out, but we certainly we're not planning to do it. But when we looked at, this is the first time we've had 3 days of joint action, we couldn't maintain safe services without taking some really difficult decisions, and that unfortunately was one of them.
Well, I think if people understand that, and it's only going to be for 3 days, they accept it, basically. I was just going to go back onto Falls. My 94-year-old auntie fell at home a couple of weeks ago. Louth couldn't actually, they don't have anybody there that can sew up the wound. She's got a really nasty wound on her thin skin on her arm. Eventually taken to Grimsby because by a member of the family, because the ambulance wait was over 6 hours for a 90-something-year-old who banged her head as well when she tumbled. When she got to Grimsby, she was not seen till the following day, and this from tea time the following day. She was on the trolley all the time. She asked for a pillow. They didn't have any pillows in A&E, and eventually there were no beds at Grimsby, and she was put in an isolation room on a heart ward, I think it was, and so people are reluctant to travel to go and get these services, and I think it's quite frightening when you're 94 and you're stuck on a trolley for hours and hours and hours. And I understand, you know, you read these papers and you think, oh, it all sounds jolly nice, but the reality of it is very, very different. And yeah, we get the public telling us what's happening, and it doesn't. You know, I can read this and I understand it and all the rest of it, but when you try to tell people this, it's another story, isn't it? So, thank you.
Yeah, and I'm sorry to hear about that. That sounds like a really not good experience for that patient, and I think that's why we're trying to invest in our frailty services and our prevention to prevent exactly that scenario. So we should have been able to manage that differently, and we clearly failed on that occasion. So please accept our apologies.
I think in Lincolnshire we're all stubborn and we don't want to go into care, and therein lies the rub.
Thank you, Councillor Atkinson-Saunders. What I will say is I think if they were looking at closing Louth overnight on a permanent basis, or Skegness, or any of the other UTCs that are open for that service, we would most certainly push for public consultation, and I'm sure take strong action to ensure that they remain the way they are. Would you like to move on to the second part of your report, please? Thank you.
Yes, certainly, Chair. I'll take it as read because I recognise the time at the moment. But so the second part of the report talks about starts off talking about our A&E departments, so the 3 current departments that we have. The level of activity, as you can see in the pack, demonstrates that activity numbers do remain really, really high, but they are fairly stable. Whilst they're high, they are stable in that terms. And you can also see the performance against the 4-hour standard, and also the number of people waiting more than 12 hours in our department. We've put that as a priority in our urgent and emergency care strategy. So we have an ambition that nobody waits more than 6 hours. Because obviously there is risk of harm after that, so that's why it's really important to us, and we're reviewing that on a daily basis. And you'll see in the pack there's some quite specific ED recovery actions that we're undertaking that will put in measures that will reduce that 12-hour wait. You can see the performance in there. We report performance in Lincolnshire for ED departments, which we call Type 1, and our urgent treatment centres, which we call Type 3. So the activity is broken down by that in your pack as well. And then we also have obviously a focus on ambulance handovers, and I've touched on that earlier. So there's lots of things that we can do that support ambulance handovers, and it's not an East Midlands Ambulance Service problem. It's a problem for us as a whole health and care system. Clearly, if we have patients waiting to hand over at our ED departments, that means that crew isn't on the road to respond to the next patients. So we take a whole system approach to that in Lincolnshire in terms of all of the different actions that we're undertaking, and some of those are detailed in your pack. I know that you heard from ULHT previously about the breaking the cycle work that they've been doing. We've also been doing quite a lot of work with Julie's team, integrating with EMAS and the Clinical Assessment Service to take lower priority calls off the stack of waiting calls, so that we can deal with them in a different way, therefore freeing up the emergency resource for the higher priority calls. And then you'll also see that we've commissioned a number of emission avoidance services, and we've done some really good work with local authority public health adult care colleagues, I'll get it right, with active recovery beds, and I know we've spoken about that previously, and they're all working really well. I wasn't going to go into the discharge and flow information in too much detail, but you can see in there the improvements that we've made since we last came and talked to you about discharge and flow. It does remain challenging for us in Lincolnshire. It's quite difficult to get that care workforce out in the community, particularly difficult in the summer, but we work really closely in partnership with the Care Association, with the County Council, and obviously across health service to do the very best that we can for that. So I think, in conclusion, I would say that we've done considerable work in the last year, given the context of the environment we're operating in. It is challenging, and we have got plans in place to continue our improvement. But we know we don't always get it right, and we know we need to do more in those areas. The system working and oversight that we have for urgent and emergency care, I think, is in a place I've never seen before in Lincolnshire. So the partnership across, whether that's voluntary sector, statutory providers, or the council, or the Integrated Care Board, I think we all have the same ambition, which is to do the right thing for the population that we serve, and I think that sets us in a good place. I know we'll talk about winter shortly, and to make it as safe as we can across our urgent and emergency pathways, whilst we continue the improvement and transformation that we've outlined in the pack.
Councillor Smith.
Thank you, Chairman. What are ULHT and partners doing to ensure that we eliminate patients who suffer strokes and other time-sensitive conditions waiting too long? I was made aware of a tragic case in my division where a resident lost his wife as she was waiting for an ambulance and then wasn't properly seen for 12 hours. The end result was she sadly lost her life. Whichever way you look at it, Chairman, for a condition such as a stroke, that is totally unacceptable, and I don't ever want to come across a story of an incident like that again, where we have our constituents losing their lives because they're not being able to access A&E and the services they need in a timely manner. And I appreciate the pressure that staff are under and everything else, but the simple fact is that, unfortunately, because of this, that lady is now no longer here. And I also have very real concerns, Chairman, that if we have a bad winter, the same problem as we've previously discussed here before will rear its head again, and it will be our residents that suffer, and tragically, as I've already alluded to, some will do so fatally. Notwithstanding the proposals within the pack regarding the number of ambulances, clinicians, etc., what's going to be done in the short term, because that is a long-term to medium aim. And with your indulgence, Chairman, I'd like to make one very brief additional question, which is on the issue of patient flow systems, the systems that surround them, and those who manage it. This may sound a very primitive question in its simplicity, but what happened to Matron, as because when Matron was around all those years ago, you didn't need 20 million different systems, Chairman. You had one system, and Matron said, right, that person needs that care when they leave this hospital, and I will make sure that piece of paperwork is signed off so they can leave hospital. Whereas now we have three different, I think in the report I saw reference to 3 different senior groups of leaders who meet for this issue. Then you have bed managers, and then you have then you actually have modern matron as is, and then a ward sister, and so on and so forth. And Chairman, it seems from a patient perspective, and again, it may be a primitive view, that this actually is not actually due to getting the result for patients, but it's actually due to how the NHS is now funded, and that is why the system is the way it is, because that is how it triggers the funding resource, so these programmes can exist, when actually in the ideal world, what it actually needs is NHS funding to be a truly national funding pot, as used to be, rather than, which I appreciate is a political issue. So Matron can say, no, that patient needs this, go away and do, rather than 20 million systems, and actually our patients get very frustrated because they don't know how it works. So they then can't articulate, or don't know who to articulate to, the problems they're suffering. The end result is we have bed block, which we all are aware of, due to actually the social care side of things and other elements not being present when our patients need it, rather than actually being in a ED or an acute ward for a medical reason. So could we not bring back Matron and solve this problem very simply, Chairman? Thank you.
Okay, so I'll take you first. Obviously, I can't comment on the individual case because I'm not aware of it, but I'm sorry to hear about that. I think what the pack does detail is it does detail some more medium terms, but it also talks about some immediate actions that we're undertaking, particularly under ambulance handovers. And we know there are 2 reasons why an ambulance doesn't get to someone. It's either because they're travelling across our rural geography or that it's not in the right place at the right time that we get the call, or that they are actually stuck outside one of the hospitals, either in or out of our county on our borders. So the work that we're trying to do is to solve both of those things. But also you'll see in there about how we make better on-scene time. So as I alluded to earlier, so if a paramedic's with somebody and they know they don't need to take them to hospital, but they need to do something, it could be their housing, it could be a whole raft of things, then we need to make that more simple, and that's the work that we're doing around the single point of access, which is immediate, and we've just had confirmation, I think it was this week, wasn't it, that we've had that funded nationally. So that's really good for Lincolnshire, because at the moment we didn't have a funding stream. We know we want to do it, but we didn't have a stream. So there are some immediate actions that we're taking, and all of those will have an impact combined together on our ambulance turnaround times. But we also know sometimes it's resourcing, it's workforce. We do struggle, particularly the further east you go, to recruit to those posts. So actually, East Midlands Ambulance Service have been given additional money to recruit this year. So the money's there, it's not a money issue, it's actually a workforce supply issue. So that's why we're trying to do as much work round as we can. We're also using some private ambulance services at the minute. So we're doing everything we can, but we do recognise that it's difficult. From a stroke pathway, clearly we've got the new stroke pathway through the acute services review. So now Lincoln is where you will go, and you'll go straight into the stroke service. So that should make significant improvements. And then we've got improvements in the in the straight pathway coming out into the community as well, which will also mean people are there for less time and should be able to focus. And I'm going to bring Julie in who'll talk to you about our new modern matron version too.
I have to say, I am that old that I remember very fondly being inducted and trained by matron. But all joking apart, our new edition of matron is about 4 people now from different organisations. It shows how awesome maybe a historic way of working was. So our integrated care hub, I think, is actually ensuring that we wrap around that expertise around our patients and their families, both from a care perspective, our local authority colleagues from community, from the voluntary sector and our acute providers, making sure that we balance off the difference between feeling, is somebody ready to be able to go home? What do we need to have in place in that timely way? And in preparation for the industrial action, looking to another colleague who brought the subject into today's conversation, actually the way that new hub is functioning is nearly as powerful as matron's word. So I am positive, as we've put these new ways of working in ready for winter and to equip us to serve our communities to the best we can, because flow is certainly at the heart of that for this winter, or any winter. I do feel that the way that new construct is functioning is positive. So I hope that assures the fact that although we're not in the times of, sort of 20, 25 years ago when that was the way we discharged. And it's not for me to comment on how we've got from there to here, but actually the pulling together of all our resources around the patient and their families, around their situation. I do think that the delivery of that service, which is now from 8 to 8 within the acute trust, in order to support flow in a really meaningful and respectful way, I do think is showing good positive embeddedness.
Thank you, Chairman. On the first point about, because you mentioned the paramedic and it might be a housing issue, and this is not necessarily directed at yourself directly as ULHT, but surely, Chairman, there's a failure somewhere if the paramedic has to be the one that notices that. That problem should be noticed by other colleagues, whether that be care in the community colleagues or colleagues from Lincolnshire County Council if they're involved with that person. It shouldn't get to the point that there's an accident and the paramedic comes and goes, actually, you don't actually really need any medical treatment as such, in the sense of you don't need to be conveyed to hospital and I've actually medically stabilised you, but there's another problem. So surely there's a failure somewhere. And on the point of matron, I'm not going to ask you, as you've said, for how we got there, but surely it's a bit of a sorry state, Chairman, that we went from one person being able to do the job to now needing 4 people to do the same. I appreciate that, shall I say, medical complexities have increased greatly within the last 20 years, and I accept that. But I'd be very interested to know if any research was ever undertaken of why it worked all those years ago with one person and we now need 4 and several systems around that. I don't know if there has been any, but I think if there hasn't, Chairman, I think there should be, because if it ain't broke, don't fix it, and it wasn't broke.
I'll come back in. I think it is complexity. So, the way in which the health service was 25 years ago is very different to how it is now. And I think it's as simple as that. It's more complex than it used to be. Pretty much you really had hospital and primary care, didn't you? And that was it. So I think that's why. And I forgot what your first point was now. My apologies.
Okay.
The paramedic, sorry, yeah. So I think it varies. I think sometimes these people aren't in contact with any services and actually it is the first time and they're now in crisis and we're now picking up there are other issues that are leading to that crisis. So they will refer off. I use housing as an example. I mean, there can be many other examples and it could be health related. So it's not always that they're not in services, but they often don't need to go in. They might need some immediate care and treatment, but it's making sure that, obviously we've got the right pathway to hand them off, because it's not then a good use of the paramedics' time to stay and solve those on scene.
Thank you. Derek?
Just to add to Claire's point about complexity, I agree about the complexity of the system, but there's also the complexity of individual people and their needs, polypharmacy, multimorbidity, they've got lots of different conditions, how they interact with each other, does require a much more sophisticated and detailed knowledge of a whole range of different clinical specialties, and that's never going to sit in one person in the modern day world, which is why we've got multi-professional groups. We see it with comprehensive geriatric assessment, where you probably need, I mean, you can do it with 7 different people, but you can probably get away with 3. But they are 3 different clinical professionals in terms of getting the best outcome, and that's a function of people are living longer, which is a good thing, but it does add to complexity.
Okay, thank you. Councillor Mackinson-Saunders?
We've done quite a lot of work with Professor, I think he's called Professor Fussy, from Lincoln University with the rural health thing. And he maintains we're not getting fair funding for the complexity of stuff going on in Lincolnshire. I was going to ask Mr. Ward how much a disadvantage are we in Lincolnshire in trying to spread the butter, let alone the jam? And should we be pressing for more funds to allow us to be able to do a lot more of these things that we think are so important?
I'm going to shy away from any political aspect here. I do think there is an inherent... The way that the Department of Health funding formula is calculated is based on quite an old model, which does look at deprivation, but it tends to prioritise urban deprivation. And if you look at Chris Whitty's Chief Medical Officer's report from a couple of years ago about rural and coastal health and challenges therein, and we had the pleasure of hosting Professor Whitty and taking him around Lincolnshire, trying to deliver health and care services in a large, rural, dispersed geography with a very large coastline, where you can only look at 180 degrees in terms of service provision unless we're going to provide services on a boat, does make it more complicated, does make it more complex, and does therefore increase the costs. And I think that's an argument that we continue to make through lots of different routes. Whether central governments of whatever colour will hear it, we'll just keep making those arguments.
Okay, thank you. I haven't got anyone else that's shown that they want to ask questions, so I've got some myself. My first question is, do you feel that the target of 76% of patients being admitted, transferred or discharged within 4 hours by March 2024 is achievable, and if so, how?
Do you want me to answer that one first? I think it is achievable, with a caveat of it really does depend on what happens with industrial action, because as that keeps escalating, our ability to maintain safe urgent emergency care is compromised. So without that, absolutely, yeah.
Thank you. My next question is, do you know what proportion of NHS 111 calls become 999 calls? And is it still the case that EMAS is not allowed to triage these calls, so they have to be treated as a Category 1 ambulance 1 response?
I don't have the data to hand, but I can certainly look into that and get that for you. There is a different pathway approach now in terms of when it's, but if it is a Category 1, it does automatically flick through, but EMAS will review it, but I don't think they can change the category till they get on scene and they've seen the patient. So, but I will double check that for you and come back if that's okay.
Yeah, that'd be great, thank you. And on page 37, can you briefly explain what a transfer of care hub is? For example, is it a lounge or are there beds, and what is offered there?
Yeah, so, Chair, this was my description of new matron. So transfer of care hub is our into the acute hospital's support in order to facilitate discharge, which, reflecting on that conversation, our length of stay in acute hospital is much shorter than it was 25 years ago. So therefore, the level of complexity and need that our patients leave hospital is also much greater. So I think for me that's an important reflection as well on the conversation around why we now need a transfer of care hub, and to bring together different points of view to make sure we are able to support those individuals who are now clinically ready for discharge but still may have complex needs which we need to support them so they can stay as well and continue to get better.
And my final question is, how will the delivery plan attached to Appendix A be monitored, and in turn, how likely do you feel that this considerable programme will be achievable in Lincolnshire?
So the way we monitor it at the moment, so we have an urgent emergency care programme delivery group that does the monitoring, and they report up to our urgent emergency care partnership board that I mentioned in the pack, and that has a wide range of stakeholders on it. That then reports up into the Service Delivery and Performance Committee of the ICB, and that is a subcommittee of the board of the Integrated Care Board. So that's how it's monitored, and that's a non-executive led committee.
And do you feel it's achievable?
Oh, sorry, yeah, I forgot that bit. I think what I think we've done a plan that is achievable if we can get on with the plan and not be distracted by the things. So there is just that caveat that at the moment, I can't tell you how much distraction there is in the planning for response and recovery from industrial action, and we just don't know how much more of that we're going to have and whether it'll escalate. So I think that aside, we've got a deliverable plan.
Thank you, and I'll allow Councillor Smith to come back, and then I'm going to make a proposal.
Thank you, Chairman. It builds on to an answer from one of your questions, actually. You mentioned that now, compared to, as you say, about 20 years ago, people are staying in hospital a lot less in terms of time for the same conditions. Now, why is that? Because sometimes it will be, I'll give my mother's example, she went in for an operation to have an amputation in her leg. Now, okay, she's quite strong and bloody-minded and determined, and she was in and out within 24 hours, which to me is a totally alien concept, because you've had major surgery, you've just had a limb taken off, and you were out of hospital within 24 hours. You know, even a couple of years ago, you were looking at least a week. They seem to get forever shorter and shorter, and I always have it may be a very old or antiquated view for somebody of my 29 years of age, but I always sit there and think, well, you're almost having it done and chucked out very quickly, and then it's care in the community or somebody else's purview. Notwithstanding the issues with beds, which we've talked about, it seems that you aren't in for half as long as you used to be, and sometimes I'm aware of several instances, anecdotally, where they've clearly been taken out too quickly and then have problems as a result later.
So there's several reasons why we look to shortening length of stay. One, going back to one of your original observations, that an acute hospital isn't necessarily the best place to be. We only have to think about the infection prevention and control issues of staying. So we very clearly make sure that we focus on acute time for that acute phase. Also, additionally to that, the whole GIRFT project, getting it first right time, particularly around such cases like the surgical one of your mother's, and I hope she's doing really well, that we've looked at a lot of evidence around how to think about what is the optimum amount of length of stay for somebody to be using those acute services. And I suppose with that, we have had the privilege of building up and knitting together much more robust community offer with our local authority colleagues, with the voluntary sector, with the third sector. So actually the alternatives to acute care are very different now in order to bridge that gap. So I think that it's sort of multifaceted, and so we only have to look to the work of, say, GIRFT and that to see the evidence that has challenged us to bring that acute length of stay down to the optimum level for the individual patient, and hopefully we get that right case by case as often as we can. Thank you.
Okay, thank you. In which case, I'm now going to move to a proposal that the contributors be thanked for their presentation to the committee, and that the committee's support be recorded for the local NHS's implementation of the National Strategy for Recovering Urgent and Emergency Care Services, and that a further update be received in the spring of 2024, or at the time of the outcome of the review of the consultation if sooner, on how the urgent and emergency care has been operating over the winter months. Do I have a seconder for my proposal? Thank you, Councillor Wootton. All those in favour, please show. Thank you, that's supported. In which case we'll now move straight into agenda item 6, winter planning. This item was circulated as part of the agenda pack on pages 89 to 96. Once again, I'd like to hand over to our presenter, Clay Roybold. Could I ask you to present the report in about 10 minutes, and then we'll take questions again at the end? Thank you.
Yes, thank you, Chairman. So we're currently in the stages of developing our winter plan. I think I've said in the report that we're hoping to take that to our partnership board on Friday. We are a little bit behind schedule, but we're still trying to aim for that to go on Friday, but we may not be able to make a recommendation Friday, and that's compounded by industrial action. That's why we're a bit behind this week. But essentially, we've been doing quite a lot of work on getting ready for our winter plan. We started our winter planning back in February and March when we were doing our normal NHS operational plan for this year, because winter happens every year. It's not a new thing, so we know it's happening, and we plan for that right at the outset. So we had a demand and capacity allocation that we've targeted against schemes that we want to recurrently fund in the NHS to improve our urgent and emergency care and our elective services. And many of those kick in for winter, partly because that's how long it will take to get them, but some of them deliberately, so that we start to see the impact in winter. So there's been some early planning as part of our normal operational planning. And then in August, we had our first system winter planning discussion, which is all of the partners across the system, so the trusts, adult care, we had the voluntary sector, and the Integrated Care Board and commissioners, where we came together with clinicians and operational leaders to say, we've got our plan, what else do we need to do, learning from what's happened during the summer, where we experienced one of the busiest summer surges in Lincolnshire from a healthcare need perspective. So that's our start point, really. And you'll see in the pack we've got a national letter which has been sent to the NHS. There's also one that's been sent to adult care with the expectations of us over winter. And essentially what they're asking us to do is to ensure we've got an urgent emergency care recovery plan covering the high impact interventions. We talked about that in the previous action. Complete operational and surge planning, so being able to demonstrate at what point we think demand will outstrip our supply and what options and contingencies have we got to manage that. We've also got to have a very clear, effective system of governance. We believe we've already got that in Lincolnshire in terms of the partnership working and how we work. It's a joint plan. It's not just one the ICB writes in a dark room and then just presents it to the rest of the system. So that's not how we work anyway. We've also got to do work around supporting our workforce, and that whether that's to get their vaccinations and being in the best possible health going into the winter months, but also in terms of supporting them with the challenges that we're facing across health and care at the moment. So we've clearly got ambitions in our winter plan, which are the same ambitions we talked about in the previous item, with the addition around keeping bed occupancy at a reasonable rate, which we currently are at the moment, but we have got escalation beds open at the minute, and most of the acute providers have, and they're being asked to maintain that through the winter months, which is a piece of work we're looking at the minute. We're doing some very targeted work on intermediate care, which is in your pack, and that's led by Afsani, who's the Assistant Director of Adult Care, and I Deputy Chair that board. And we're looking at rebasing intermediate care anyway across the county. We've got a fragmented service and different offers, and learning from the really good work we did with active recovery beds that actually turned out to be a real success. That's the model we want, where we're wrapping therapy and support around those people to get them out of hospital so they don't decondition, but get them ready and back home, wherever home might be for that individual. So we're looking at some quick wins that we could do over the winter months with some of our other beds. So we have what we call transitional care beds, which was the prior version of active recovery beds, but they don't have the advanced therapy input that we have for our active recovery beds. So that's in our plan. Obviously, there's quite a lot for the Integrated Care Board in terms of oversight. I already mentioned the System Control Centre in the last presentation. The System Control Centre is designed to be that kind of operational centre, really, of the system that understands what's happening across urgent and emergency care, but also across elective and cancer. It's really clear, given the size of our waiting list in Lincolnshire, we need to maintain as much elective and cancer care as we can. And historically, we plan to do less of that in the winter so that we can manage our urgent care pressures, and we just can't do that this year. We've got to keep our focus on elective and cancer. And obviously, you know, I've referred to the industrial action, but obviously the impact that that has, we're reworking all of the time. And we are expecting, you know, in our planning, we are planning for that. We don't think that industrial action is going to go away. And what does that mean? There's also quite a lot in there about energy, adverse weather. We work with the Lincolnshire Resilience Forum. In fact, we had a meeting yesterday, Derek and I were both at that, about how we work together as partners around some of those other impacts that we have, whether that be flooding or severe weather in Lincolnshire, which we're well versed in dealing with. We've also got quite a bit about infection prevention control, as you would expect. Vaccination is a key delivery arm for us. We know that the vaccination programme for COVID has been brought forward this year, which is great, and we've got really, really good uptake amongst our population and our staff. But obviously, you know, as we get towards the end of the winter, there is the risk of waning of vaccine because we've gone early. So we need to be cognizant of that in our plans as well. So in terms of what we're doing, we're pulling all of that together. You can see in the pack what we're doing. We've got a very detailed document that we have to submit to NHS England, which is a set of key line inquiries really about what we're doing and how we're working across the system, which we've already submitted, and we've had some positive feedback on that so far. We have a winter planning assurance visit on the 10th of October where NHS England colleagues will come and assess where we are from a winter plan. They're going to walk through some of our urgent care pathways as well on the hospital sites. So we've got that coming up, but we're really clear that we will do exactly the same as we did last year. We will develop a plan. We will keep it agile to make winter as safe as is possible with all of the moving parts that we're dealing with. I did get a question at integrated care partnerships, so I will just mention it here in case it comes up again around children and young people, and you'll see that in the plan. This plan isn't just for older people, it is for whether you need urgent care, whether you need elective care or cancer, and it's for children right the way through to adults. We know that was a particular issue for us last winter, as you'll recall when I came in March, particularly with respiratory infections and paediatrics, so we've got a real focus on that in our plan so far this year. But very happy to share the plan as soon as we've approved a draft, which hopefully will be this week. If not, it will be in the next week. Very happy to share that with colleagues. Thank you.
That'd be great, thank you. If you could. Questions, please. Do we have any? Councillor Guiney.
Sorry, just a couple of questions, basically on personal experience. I was due for a minor operation, and over 3 months ago I had all the tests to confirm that I was ready for it. I would think it's almost certainly because of the industrial action, but can anything be done? Because obviously I wasted quite a bit of NHS money, both having the phone call and going to the hospital to have all the tests done, which will now have to be redone before I can have the operation, because I believe 12 weeks is the maximum that the tests are reliable for, therefore they'll have to be done again. And the second question is there a strong case for putting in COVID treatment again this winter? I've just recovered from it, and I think I gave myself about 2 hours to start to be able to breathe with any ease before I was going to ring an ambulance. I am one of the sort of older category, which means that, but I had all the jabs that I was supposed to have. I understand from speaking to other people, it's quite a severe case of COVID is rife at the moment. Is in the winter plan there some allowance for increase in hospitalisations for people with COVID? Thank you.
Thanks for your question. So just in the first case, obviously, without knowing the detail, but I'm happy to have a conversation with you offline about your cancellation. So clearly we are cancelling a lot of operations and procedures at the moment because of industrial action, and there isn't a way around that, unfortunately, at the moment, where we can keep them going and in context. So if I just take one of the last days of action, we cancelled around 150, but we still saw 2,000. So we're seeing as many as we can, but particularly surgical cases are ones that get cancelled because anaesthetists are quite high in the strike rate. So it varies obviously on different days. So, but I'm happy to pick up your particular case if that would be helpful. And then from a COVID perspective, so COVID treatments for those that are vulnerable that have always been in place still remain in place. So if you had an initial letter that giving you access to the kind of antibiotic COVID treatment, then that still exists. So those services are still there. In terms of what we're predicting, so we've been working with public health colleagues around the predictions for winter. We're not expecting it to be any worse than last year in terms of COVID, and we are seeing a little bit of an uptick at the moment, and obviously then it spreads into staff. But we're not predicting it to be any worse than last year, and that will be in our winter plan.
Any further questions? No, I've just got one. In terms of the weather, what is the best for the NHS? For example, would a mild winter create different issues to a severely cold winter?
We're all fighting over it because it's such a good question. So winter extremities cause different problems in different ways, don't they? So as a chief operating officer in the community, severe weather, whether that's floods or snow, is not on my menu, please, Chair, because logistically it's really tough. It's really tough for our staff, our people, to prioritise the ability to come to work with their own personal commitments, school shut, those members of their family who they're responsible for are now becoming more vulnerable. So from a practical issue, weather is really difficult. Also looking to Derek and others, we know that 10 days after a really cold spell, we can guarantee an increase in respiratory. So we also then know the minute it starts to go cold, we need to change our respiratory response. On top of a practical conversation we've already spoken about lots in the first item, falls, that it's really difficult to suggest to the public, please be careful, do not go out while there is snow. Stop your life. This is a very difficult ask of our citizens, hoping to keep them safe, not to then become potentially patients. And then I think we know the catalogue. So as a chief operating officer, if I could request a really mild winter, I would be grateful. But absolutely, being very serious, this is what we plan for. This is what we're good at thinking through. We understand as well the knock-on effect. But fundamentally, this is the bedrock of the winter plan. We will plan for the worst weather with everything else thrown in as well. But it's definitely off the menu if possible.
Thank you. Before I bring Derek in, I think I read this morning that we're looking for a quite harsh winter. So sorry about that. Derek.
No, I'm just conscious we're in scrutiny, so I was going to second Julie's proposal there, if I may.
I think we'd all agree on that one wholeheartedly. Thank you. In which case, I haven't got any further questions. I'd like to once again thank our presenters for the presentation this morning, and also that I suggest that the actions undertaken by the NHS and other partners in preparation for winter be supported. Do I have a seconder for that proposal? Thank you, Councillor Hayes. All those in favour, please show. Thank you. That's supported. Thank you. You're free to go. So we'll move on to agenda item 7. The work programme. Simon, I'm going to hand over to you. I think with technology, you'll go on in.
Yes. Good morning. Good morning, Chairman. Apologies I'm not in the chamber this morning. If I could draw the committee's attention to pages 98 and 99 of the agenda pack, which sets out the list of items for the next 2 meetings. We do have a long list for the 8th of November. I would highlight the Lincolnshire Humber Acute Services Review, which is the consultation for that review is now underway. There is also an item which the committee may be, they may not necessarily understand where that has come from. Number 5 on the list the committee is going to be asked to consider whether it wishes to put forward any potential topics for an in-depth scrutiny review. As I say, I'm happy to ask questions and on items listed for the 8th of November and the 6th of December. Thank you.
Thanks, Simon. Any questions, please? No, nice and simple this time. So I propose that we support the work programme in its form. Supported? Oh, good. Thank you. Let's move then. And thank you all very much for your attendance today. It's a shorter one today, but I'm sure it'll be much longer on the next one. So thank you all very much. That's the meeting closed.